Well, I'd like to thank Dr. Friedland for joining us today. My name is Robert Enns. I'm from St. Paul's Hospital in Vancouver, in Canada, and our topic that Dr. Friedland has joined us with today is Barrett's esophagus. He joins us from Stanford and VA in Palo Alto, and we really appreciate him coming out today to discuss his paper, which is really exciting in the area of new methods in regards to Barrett's ablation techniques. So I wanted to start out and basically ask you, can you tell us a little bit about Barrett's prevalence, background for the paper, and your thoughts on where Barrett's is going?
Yeah, well, as we all know, Barrett's esophagus is a real problem, a precursor lesion to adenocarcinoma of the distal esophagus. It's increasingly recognized, particularly in patients with chronic reflux, and most commonly in the sort of the white male population. There is a risk of progression from non-dysplastic Barrett's to dysplastic Barrett's and then to adenocarcinoma. And we're all here trying to figure out what we can do to prevent it.
Fantastic. And I think this paper is another technique which is just absolutely fantastic in regards to ablation and getting rid of Barrett's esophagus. And I think all of our patients love the idea of getting rid of it as opposed to just watching it. You want to describe some of the present ablation techniques that are out there before we get into this new one?
Yeah, well, ablation of Barrett's has a long history. It really started with techniques like PDT and bipolar cautery, and has evolved into the two techniques that are presently used. And one of those is radiofrequency ablation, which is done with a balloon catheter. And the other technique that's become somewhat more popular in the last few years is cryoablation with the cryospray.
And what are the advantages and disadvantages of cryo versus radiofrequency ablation?
Well, we practice both at our institution, but the radiofrequency balloon is more well established, particularly in the U.S. It uses a relatively rigid balloon that's first you have a sizing step to figure out exactly which size catheter you need, and then you inflate that balloon for a short duration. You generally scrape the mucosa and repeat the process. From our point of view, it's a very effective procedure, but it's relatively cumbersome. There are several exchanges of the scope and guide wire that need to be done. There's a sizing balloon, and then there's the ablation balloon itself. So the procedure takes us, when I do it, maybe between 30 minutes and an hour. I usually have to have an anesthesiologist in the room because there's a lot of scope exchanges. And the balloon is relatively rigid, and the esophagus in a lot of these patients, as you know, is not completely tubular.
Absolutely.
Now, cryospray, on the other hand, is something that can be applied to a wide field. It is under the direct, is sort of done through the scope. But you have difficulty in visualization because you're spraying a large amount of gas volume in there. Things get relatively cloudy, so it's difficult a bit to control the application. An advantage of cryospray is that the patients, for whatever reason, and I'm not sure we understand it, don't seem to develop the same kind of severe chest pain that's common with radiofrequency ablation, and that's been touted as a real advantage.
So in this study, you looked at, if I recall correctly, 12 swine, and you looked at their esophagi, and can you describe how you went about the study and what exactly you did and what you found?
Yeah, so we were trying to develop a device that sort of combines, from our point of view, the best of both worlds in that it's a cryo device, but it's within a balloon. So the cryogen is contained within a balloon. It passes through the scope, and you apply it directly under direct vision through your endoscope. We tested it in swine, and we wanted to see what is the optimal temperature, duration, etc., to make sure we can ablate the mucosa without causing too much damage.
And so you have a cartridge that fills up the balloon. My first thought is immediately when you're filling up a balloon at minus 70, minus 80, that the balloon might fracture or crack or freeze in some way.
Yeah, and it's very important, of course, to test for all of these possibilities. Remarkably, there are materials that you can make balloons out of that can withstand that temperature, and also materials that are relatively flexible, so they'll conform to the shape of the esophagus. What we'd like to do is basically to inflate it to the point where it's pressing on the walls of the esophagus, at all the walls, no matter what the angles are, without applying so much pressure that it could burst the esophagus.
And in this study, what did you find as far as your optimal settings for use of cryo?
Well, what we found was that we were able to, using this particular cryogen, which is liquid nitrous oxide, which tends to have a temperature of minus 80 degrees, it generates just the right amount of pressure from our point of view to distend this balloon without causing trauma to the esophagus. When you inflate that for a certain amount of time, you have to figure out what is the optimal amount of time, and what we found with trying different lengths of time is that at least in the swine model, with about 10 to 12 seconds you can ablate the mucosa reliably, but not so much so that you're causing severe strictures.
And then, you sacrificed. You looked at the esophagi, and you found that if you went more than 12 seconds, you tend to get stricturing rates?
Exactly,
okay.
Exactly. So we were fortunate in that we were able to find a duration of time that can reliably ablate the mucosa, but is short enough that you don't get severe strictures. And certainly as you increase the duration of time, you will get strictures. And pigs seem to stricture relatively easily, at least from our point of view as experimentalists,
And where do you think, so obviously this is really exciting, because it would be nice to have something through the scope, because we're all used to passing instruments through the scope. It'd be nice to have something relatively quick with minimal exchanges, and I certainly agree with you that RFA, although it seems to work relatively well, does have some hassle factors with a lot of exchanges. Where is this going next? Where's next steps? You seem to have a balloon, a device that seems to work, at least in the swine model. Where's this going to next?
Well, that's true that it does seem to work in swine, and working in swine is, as we know, not the same as working in patients. And so the next step is, now that we've established that it seems to be safe in the animal model, the balloon doesn't fracture, it seems to deliver what we want it to, and we have a pretty good guess as to the right amount of time to do these ablations. The next step is to test it in volunteers, and what we've chosen is similar to some of the prior studies, is to recruit volunteers who are about to go on esophagectomy for esophageal cancer, and they're kind enough to volunteer to have an ablation shortly before that, and we can see the effect and pathologically measure, is this ablating the mucosa, is it causing any damage, and that's been started. Yeah.
So that's been started already.
Yeah.
Any anticipation on completion of a group of those patients?
Yeah. Well, there's been several patients that have undergone the treatment in Amsterdam, and so far they've tolerated it quite well. I heard one of them wanted to go eat immediately afterwards, so that was encouraging to me that that it
Great.
wasn't causing pain, and so hopefully we'll be able to move forward soon.
Well, I want to thank you for spending some time with us today. I think this is an exciting development, and hopefully will be a device that will be available for use over the next few years, and also give us just a simpler device to use that'll benefit our patients. So thanks again for your time today.
Oh, it's a real pleasure. Thank you.
Thank you.